Thank you, Kennedy, and thank you, Jessica. Welcome, everyone. So my name is Isabelle Morgan, and I am a doctoral student at UNC Chapel Hill in the Department of Maternal and Child Health. I'm also minoring in epidemiology. And outside of UNC, I have the pleasure of working with phenomenal women like Kennedy and folks at the National Birth Equity Collaborative as part of the Birth Equity Research Scholars Program. So we hope that you were able to tune into the opening sessions yesterday. As this virtual summit is focused on looking ahead and moving forward, today in this session, you'll be hearing panelists share insights on emerging opportunities for data measurement and management. I think it's important to highlight and reiterate some of what was shared yesterday in the opening sessions to help with level setting for this specific panel discussion. The conference organizers acknowledge that preconception health language is limiting, particularly in that the original conceptualization of the preconception health framework focuses primarily on individual level behaviors, which can detract from structural factors and systems that impact one's overall health and wellness. In fact, there have been efforts to move beyond the preconception health framework. So for example, in February of this year, Dr. Christine Dellendorf and colleagues, including Monica Simpson of Sister Song, Miriam Young, formerly of the National Asian Pacific American Women's Forum, and Dr. Joy Creer-Perry of the National Birth Equity Collaborative, along with other contributors, published a call to action to center reproductive and sexual health equity, and that was published in Obstetrics and Gynecology. Further, yesterday, as panelists were sharing the amazing work that they're doing, they also described their expansive visions for health and wellness. And we heard the importance of gender affirming care. So in this session, we also want to uplift the importance of gender inclusive language. I do want us to acknowledge too that we come from different backgrounds and have different affiliations, which might impact the language that we're using. So I want us to try to hold all of those things in this session. So we're aiming to hold the discussion between panelists for about 45 minutes. We'll reserve 10 to 15 minutes for Q&A towards the end. We welcome your questions and reflections. And if we have access to the Q&A feature, we'd actually prefer for you to use that feature so we can keep track of those questions. So with that framing, I will now introduce our wonderful panelists. We have Dr. Ekwetasi Okoro, who is a lieutenant commander in the United States Public Health Service and is currently the team lead for the Maternal and Child Health Epidemiology Program in the Division of Reproductive Health at the Centers for Disease Control and Prevention. We're joined by Sarah McCracken, who works as the State Systems Development Initiative Project Coordinator for the Women's and Children's Health Section in the North Carolina Division of Public Health. We're also joined by Dr. Deidre Quinn, who's an Advanced Research Fellow in Women's Health with the Center for Health Equity, Research and Promotion at the VA Pittsburgh Healthcare System. Dr. Quinn is also an adjunct instructor of medicine in the Division of Internal Medicine at the University of Pittsburgh. And last but certainly not least, Megan Williams, who is a research associate at the Collaborative for Maternal and Infant Health at UNC Chapel Hill. So welcome panelists, and thank you all for joining us today. I also want to make space for Rio. So you had a brief introduction to Rio, but Rio, if you don't mind introducing yourself and sharing with us how you'll be participating in today's session.
Absolutely. Hello, everyone. It's so lovely to see all your faces again today. My name is Rio Holiday. I'm a graphic recorder based in San Francisco on Ohlone land. My background is in public health, and I will be doing three things during this session and the sessions today. I will be listening, synthesizing for key themes and quotes, and then the part that you'll see at the end, I'll replace my camera with my iPad screen, and you can see the documentation using both words and images of what the conversation was about. This is a reflection of your conversation, so I invite changes, additions, and interactions. Thank you, Isabelle.
Wonderful. Thank you, Rio. We can't wait to that what you're going to show us at the end of the session. So why don't we get started, have our panelists join us. It would be helpful if we provide an overview of what measures, when we talk about preconception health, and we're talking about indicators related to health prior to pregnancy, what's currently available at the clinical level, at the state level, and the federal level. So why don't we start with you, Dr. Okoro?
Sure, thank you. Thanks again for this opportunity. I I'm just going to provide a very, very high level view, and I'm not going to get into any specific indicators because, again, the point of this is not for us to continue to talk about what's been done, but how can we move forward. So in general, work around addressing preconception indicators has been going on for about 15 years. The first effort occurred in 2006 when the Select Panel on Preconception Care work group published 10 recommendations promoting preconception health and healthcare for women of reproductive age. And then following that in 2007, the same panel convened a voluntary group of maternal and child health program leaders and epidemiologists from 7 states to basically help them develop a 45 core state preconception health indicators. The point of this work group with the additional stakeholders was to assess the usefulness of these indicators and whether these lists needed to be condensed further, because 45 is a lot for anybody to deal with, that could help states better set priorities and implement system changes that would lead to improvement in the health of women of reproductive age, especially during the preconception and interception periods. As they were going through this evaluation and assessing, they actually realized that very few of these indicators focused on preconception care that targeted healthcare system change. And I think that's something that Ms. Morgan mentioned earlier, that there's some limitations around systems healthcare change. So in 2016, they decided to have another meeting to talking about consensus indicators that will focus on preconception wellness. So we started with preconception health, then we moved to preconception care, and then now we started to think about preconception wellness. And basically the point of this newest piece of it was to kind of think about quality metrics that will help improve healthcare delivery within the healthcare systems. And the hope is that with the inclusion of these wellness indicators, we'll be able to assess issues at the initial prenatal care visit, that we'll be able to do quality improvement tools, and be able to make sure that the healthcare system is performing to really help women optimize their health status prior to pregnancy. Because we're a working group and we always want to do something to improve. Again, we met in 2018 as a group, this time again in partnership with the CDC group, to further narrow all these indicators. So we started with the 45, that went down to 10, but again, that was for the healthcare indicators. So in 2018, we decided to focus on the preconception care and the preconception wellness piece of it, which was something that we hadn't done. And during that effort, not only did we just think about what was available, but we also wanted to make sure that they were in alignment with the Healthy People 2020 objectives. We also wanted to make sure they were in alignment with the National Quality Forum measures, and really trying to make sure that as we're recommending these indicators, these are things that states could have access to, the types of data. So whether it was BRFSS data or PRAMS data, making sure that these were surveillance opportunities that state could really monitor the health of their population. During this latest iteration of our assessment, we actually found 80 potential preconception care indicators. And after doing additional evaluation, speaking to stakeholders, consulting with subject matter experts, the list was narrowed down to 30 that again focus on preconception care. And that's kind of like where we are at this point as of the literature, in terms of we now have these 30 indicators that prior to COVID, the hope was that we were going to start trying to really go out into the states and help them think through of how could they use it. Could this 30, similarly for the preconception health that was narrowed down from 45 to 10, could this list of 30 for care be narrowed down to a more reasonable numbers that states could use to keep track of their healthcare? Their population. So that is basically a quick overview. I saw somewhere in the chat that somebody was asking about access to the numbers. Some of the papers that were offered prior to the session has the full listing, and we can definitely send a link again out to those papers where they actually go, they have the tables where they talk about each of the individual indicators in more detail. So I will stop there, Ms. Morgan, and let me know if you need to add anything else.
That was wonderful. Thank you, Dr. Ekwitasi. Absolutely. It's really lovely to hear about that transition from care to health to wellness and how we're thinking about overall health and wellness for people prior to pregnancy. I do want to bring in Dr. Quinn and Sarah to talk about what these indicators look like at the VA, but also at the state level.
Sure, so I can start sharing some experience we've had attempting to access these indicators. So we recently completed a study in the VA, so one large national health system, and we were trying to access the 9 preconception wellness indicators that Dr. Okoro just mentioned. We had 2 goals with the study. The first was to see if these indicators are actually practically accessible in the health record, like is this actually something a health system could use to assess preconception wellness. And then second, we wanted to get a sort of preliminary assessment of how our patients within the VA system were doing in terms of preconception wellness. So we encountered a variety of snafus, the first of which was that we were only able to access 8 of the 9 indicators in our large national data set because pregnancy intention is not a variable that's collected by VA. So that's one of the 9 preconception wellness measures, and we weren't able to assess it. But the other 8 we were. Another slight snafu that we had is that the indicators that Dr. Okoro mentioned, they were designed to be assessed at the first prenatal care visit. But because within VA, prenatal care is outsourced to the community rather than provided in-house, so we're relying on external medical records to give us that first prenatal visit. So for some of them, we weren't necessarily assessing it at the first prenatal care visit. We looked further backward in the health record, but we were able to see 8 of the 9. And we found really a lot of inconsistency in the documentation of routine screenings, which was a little surprising to us. So screening for things like tobacco use and depression, screenings that we think of as being very standard in primary care, but just a lot of inconsistency in the documentation of them and how they're recorded and by whom they're recorded and when. And that really made it a little bit difficult to draw conclusions about the pre-pregnancy wellness of our population, because just because it's not documented doesn't mean the screening didn't occur. We don't want to make, wide assumptions about the fact that we might not be asking women these questions, but we don't have a record of them. We also have within VA the possibility that our patients may have outside primary care or specialty care providers in addition to their VA providers. So some of these indicators aren't as easy to access from the health record as it might seem like they would be, which was an adventure. I mean, there are always many adventures when you're going through large national data, but just not seeing exactly what we expected just in the health record. And our study obviously was retrospective. So we were starting with patients who had a pregnancy, and then we started with the date of that pregnancy outcome. We counted backwards to sort of get to their last menstrual period, and then backwards again to capture a pre-pregnancy time frame, which did give us it was a good way to use the administrative data. But thinking about these indicators, there are definitely challenges, particularly if you wanted to think about real-time assessment by providers. I would say that these indicators were not as easily accessible as you might hope, at least in our national data. So that was our experience. But I know Megan has a slightly different experience, I think.
Yeah, I can go ahead and jump in. I also worked on a very similar study as Dr. Quinn. We actually looked at 2 health systems within the same state and tried to compare, really where we looked to see whether we could access the preconception health indicators in both of those electronic health records as well. And we found a very similar, we came to a very similar result as Dr. Quinn did. We had quite a bit of missing data. We had one indicator that we could not access either. And what we ended up doing, it was also for the pregnancy intention indicator, we ended up using a surrogate indicator because we felt that we might be able to get some data that would kind of be maybe even a better substitute for that intention indicator. So we used family planning counseling as our surrogate measure for that indicator. And so we got some data for that, but we had trouble also with the tobacco use indicator, which, as Dr. Quinn mentioned, is usually a really basic screening that you give to every patient. One of our health systems that we were looking at did not have any historical data for the tobacco use indicator. So it was like a real-time field that changed each time the patient was seen. One of the other problems we had as well was we were looking retrospectively. So when a patient came in during the pregnancy for their pregnancy care, we didn't necessarily have any of the information prior to that pregnancy. Oftentimes their medical record would kind of show up as a PDF that was then filed, you know, in somewhere in the medical record, but it wasn't queryable in any way. So we couldn't, oftentimes we had no data from the preconception period that we could pull from. And so we were using kind of the first pregnancy visit as our preconception health indicator. Another thing that we found was that some of the screenings and other information that we would have liked to have been able to query perhaps was in a notes field or some other place where it really wasn't easily accessible or usable. And like Dr. Quinn, we suspected that a lot of this care was being provided. It just wasn't being documented well in the medical record. And so if it's not there practically for the clinician to be able to use in a visit, it's not really serving the purpose that we would like it to.
Thank you, Megan, and thank you, Dr. Quinn. We're seeing in the chat that there's questions about the preconception care, preconception health indicators. So I think we might want to take a step back. So if panelists, if you can provide some more insights on what specific indicators, you've talked about the ones that you've had challenges with, but giving an overview of what the indicators are, that might be helpful for the audience.
Sure, so I can share what the 9 preconception wellness measures were from the frame paper that we were basing our work on. And I think that's the same work that Megan was just discussing. So the 9 indicators are pregnancy intention, access to care, preconception multivitamin with folic acid use, tobacco avoidance, absence of uncontrolled depression, healthy weight, absence of sexually transmitted infections, optimal glycemic control in women who have pregestational diabetes, and then teratogenic medication avoidance. So you can see that there are sort of a range of factors that would be found in the health record. Some, like we said, in a screening interaction between a provider and a patient, some coming directly from lab data, at least in our case, the STI testing and teratogenic medication avoidance was coming from lab data. So you're talking about, at least in our situation, combining multiple sources of data to get at these 9 indicators.
Thank you, Dr. Quinn. Did other panelists want to add specific details related to the preconception care indicators?
I'll just add that as part of the point, we were trying to determine how many of the people in the clinics were getting pregnancy intention, were being asked about pregnancy intention. I mean, that was the whole point of the coin, is to create a way to make sure that people were being asked about that. And in our clinics, we had 3. It was really hard to capture that data. That there was not a data element that was already in their management information system. They had to either put in a dummy code, and that was cumbersome, and it just didn't work well. And even MAHAC, which Megan worked with, they did a better job of capturing it, but it had a low percentage of women who ended up being asked about pregnancy intention, even though they had lots of training on the screening tools. So again, it goes back to what Megan and Dr. Quinn were saying. It may be that they were asked, it just didn't get put in the notes. If it's not in the notes, it didn't happen. I mean, when you're looking for data. So yeah, it's more of a, if we really want to know this, then we've got to come up with a better way to capture. And then
Thank
the
you,
other
Sarah.
thing is when we were, are you going to jump to like the surveillance measures that are different from the clinical indicators? Is that?
Yes, please jump in.
And again, I feel like we've got the expert on here, so please take over for anything that I say wrong. But when they condensed them down into the set of 10, it's really from behavioral risk factor surveillance system and the pregnancy risk assessment monitoring system, BRFSS and PRAMS, and it's current smoking, depression, diabetes, folic acid intake, heavy alcohol consumption, hypertension, normal weight, physical activity, postpartum use of a most or moderately effective method of contraception, and unwanted pregnancy. So they correlate with the clinical indicators, but aren't exactly the same. And I will say that for North Carolina, you know, we have BRFS and PRAMS data with the normal caveats or pitfalls of those, that response rates vary, that so if we want to compare across the nation, that's not always possible because some states will have their estimates included or not included in national totals if they didn't meet their thresholds. You have to be mindful of confidence intervals and small sample sizes, particularly among subgroups, that you really will probably have to combine multiple years in order to get race or ethnic specific subgroups. And you know, with the weighting, that's not something that just anybody can do. You kind of have to make sure you've got some statistical software that can be done. It has to be done nationally and then brought back to the state. So it's just not as simple to get when on a practical matter, county level data. We're not for some of these measures, but that's what our state wants. We have 100 counties, they want county level data. And it's hard to say, sorry, we don't have a sample size that can do that.
Thank you, Sarah. And we heard most of what you shared. I did want to note that your audio is breaking up a little bit, so you're coming in and out. I don't know if that's something that you can address on your end. But I think it's important for the audience to keep these in mind as the panelists were sharing the different challenges that they've experienced at the federal level, at the state level, and in clinical settings on trying to actually measure, like capture these preconception care, wellness, and health indicators across the different settings. When we move into the discussion, talking about what needs to be changed and where there's movement, I would like for y'all to keep these challenges in mind. So moving to our next question, we know that there are racial and ethnic health inequities that Black women and other people of color with the capacity or the desire for pregnancy experience really across the life course. And there's more evidence that's demonstrating the impact of structural determinants, including structural racism, on racial inequities and reproductive and maternal health. So we've seen some really groundbreaking research on structural racism and preterm birth, on low birth weight, even on pregnancy-related mortality. So as we acknowledge systems and structures that impact health outcomes and well-being, how might we contextualize our data so that we're avoiding perpetuating limiting narratives about populations who are most burdened by health inequities? And anyone can address this question.
I'll take a stab at it. I think one of the things, at least from a national level, that we're trying to be more mindful of, and I think there's been more and more conversations about it in this concept of decolonizing data. I think one of the important areas, and especially we've seen this when we do deal with data related to Indigenous people, where the reference group tends to always be the white population, which is not always accurate because for example, with the Indigenous people, you know, those that are in the urban setting are very different from those that live on the reservation. And if you're using white in general as the comparison group, you're not really comparing. It's important to compare urban to urban and those on reservation to those on reservation. And I think the same could matter for all of the different populations. Like, you know, when we talk about Black women, you have those that are from Caribbeans, those are from Africa, those that have been in the United States for generations, and comparing the differences between that group would provide more richness in the data than necessarily always using white as the reference. And I know that's something that there's been more and more conversations about. I will say that it's an ongoing process. And I know we're specifically talking about preconception care. And as we're thinking about the indicators in general, and just think about what Dr. Quinn and Dr. Williams referred to, is how do we get, because the key is we only have good data depending on how it's collected. So how do we get more in buy-in at the lowest level, at the community level, at the hospital level, so that way by the time either we're looking at it from BRFS or PRAMS, it's something that's really useful, not only to the overall population, but to the specific groups and making comparisons. It's a very complicated process, but I think the key is that we as researchers who are interested in this have to continue to advocate for the desire to make sure the data at all levels is collected as appropriately as possible.
Thank you, Dr. Okoro.
I was just
Are
going
there
to say,
other reflections?
add on to that a little bit. I think this probably is something that we all, as researchers, are very well aware of, but just something to be constantly thinking about, the context of the data, where exactly it came from, and how, and as Dr. Akor said, how it was collected. So in the VA, for example, race and ethnicity data is self-reported by patients when they first enroll in VA care, when they first enter the system, it's self-reported. So we do, but as always, there are limitations in the categories that are selected in our sort of administrative pot of data, but it is self-reported. But in other situations, you might have data that race being recorded by an external observer, an interviewer, or an intake person at a hospital system. So just thinking, when you're thinking about the data, making sure you understand how it was collected, where it came from, and how that might be impacting the data itself, what biases might be at play based on how it was initially recorded, and who we do or don't have information about. I think it's just something we are constantly keeping in mind, although I don't have a necessarily ideal answer or solution for that problem, but just something to always be thinking about when we're thinking about this data.
And I apologize for internet being wonky, but one thing in addition to that with trans data especially, once the baby's born and you're asking a mom questions, a birthing person about questions about their child, it's a lot. Recall bias changes things when you have a baby in your arms, and that's just something to keep in mind as well.
Thank you, Sarah. I intentionally asked that question. I know it's tricky for each of you because of what's the data that are available, right? So there's the preconception care, wellness, and health indicators. They're focused on individual level behaviors, right? But it's about, when we think, with that being a limitation, us being very cognizant of how we can contextualize those data. So we don't have all of the answers, at least naming that this is a limitation, at least naming that these individual level behaviors, that they occur within a context, within these larger systems and structures, until we're able to push and advocate for better, more comprehensive data being collected, either through BIRFIS, through PRAMS, and through other data systems. Thank you. So now thinking about the implications of these data, how have data on individuals' health prior to pregnancy been leveraged to inform clinical care, to inform policy, and to inform funding decisions?
I would just make a comment that as far as clinical care goes, I think one of the findings that we had was that it would be pretty difficult for it to impact how clinical care is being provided, because we had so many access issues in the EHR. And so I guess I would make the argument that we need to make them more accessible in order for us to be able to use it more adequately in the clinical setting.
I think some of the conclusions we drew very similar, that it would be hard to use these indicators to immediately impact change. But our thinking, at least in the VA, based on our findings, was that there maybe were some sort of low-hanging fruit type things that we could do more easily. So one of the things that we found was that we had a very low, in women who had pregestational diabetes, we had very low recorded HbA1c, hemoglobin A1c values for those women. And that we know that these women are being assessed, they're in primary care, we know that they're receiving treatment for their existing diabetes, and somehow we're just not getting the values easily accessible. So maybe a primary care reminder, what we've proposed is some sort of very basic clinical reminders that would pop up as part of our EHR that would enable providers to just make sure that they're capturing some of these key screenings. And maybe it might feel redundant or they've asked it before, but it would just be a quick, oh, you don't see it in front of you, ask the question again. And there's always, the concern about adding burden to providers who have a very short period of time with a patient and many questions to ask, many things to consider, but that there are probably some pretty simple, at least in the clinical context, some pretty simple ways that we could leverage these data a little bit. Now, making that actually happen in the clinical setting is an entirely different set of processes. But I do think we felt at the end of our study that there were some maybe easier, small, like clinic level policy changes that could happen, whether maybe not at the system level, but at the clinic level.
I will just add that, you know, the question was how has it, and I think that that's the hard question. I mean, our hope was and is still that the more we talk about these indicators and try to get them used, you know, even despite all of their limitations, that it will help us to continue to keep it in conversation about the limitations of them and how do we need to move forward. Because, you know, one of the things that we realized as we were doing all of our iterations is that there's so many areas where there's a gap that there are no indicators for. You know, in the next couple of years, we're going to have, you know, there's nothing about any kind of weird COVID-19 based issue and how's that going to play a role. So our hope was that the more we use them, then, you know, maybe it doesn't change policy quickly, but if it affects maybe how healthy people metrics are used and decided upon, or how some of the national quality forum indicators are decided, in making sure that all these things are speaking together and they're not working against each other. I think that's the hope that we would have, that it makes more sense. And another area that we are really interested in, and it's kind of related to this, is the whole idea of severe maternal morbidity, which is slowly, there's the algorithm that's been set up by CDC. And the hope is that's the indicators could potentially feed into that, because if you know where women are at the beginning, and as they go through their pregnancy and they have morbidity, you could have some way of trying to keep track of it. So I think we're at kind of like at the cusp of getting to the place where all of these things will eventually work together. And I think these kind of forums allows us, not only the panelists, but those that are in the audience, for us to think collectively together. Like in my area, what can I be doing to try to make sure that all of these things come together? Because our goal is we want to improve health, and what role can I play that helps the overall picture? So it's a hope. We're not quite there yet, but I think that there's chance that something will change.
Thank you. And thinking about the challenges that panelists have shared related to these indicators, I'm wondering about the feedback loops that exist. So when they're experiencing challenges at the clinical level, experiencing challenges at the state level with accessing and measuring these indicators, what sort of supports are available? And if not available, what supports would you all need to be able to improve upon accessing these indicators?
I think Megan and I, we spoke offline about this before, but we both had one thought that what we really want to see is a universal electronic health record, that is what would enable us to more easily access these sorts of data points, and that something like that would solve a lot of our problems in terms of patients who seek care in multiple environments, or through receive care in different locations or from different sorts of providers and different systems. That some sort of universal record would make accessing these sorts of things much easier. I'm not sure how we do that, but I think that's my pie in the sky wish for support, would be a universal health record.
To kind of piggyback on that, I think it's important for us to always kind of keep in mind the fact that we, especially the sites that we studied in North Carolina, that we're dealing with an insurance situation that's really precarious for a lot of people, that oftentimes they're eligible for Medicaid while they're pregnant. And so, because the poverty line, the eligibility standard is a lot higher, the income can be a lot higher for them to be eligible for Medicaid. But then as soon as they're not pregnant, as soon as they have the baby, within 60 days, they're no longer eligible for Medicaid. And so we have the situation where folks that are of low income, at least in North Carolina, have essentially no access to medical care, or they have access to sort of safety net providers. And so they're kind of cycling in and out of the healthcare system with their pregnancies. And so it's really difficult to provide care during those non-pregnant periods, but it's certainly difficult to manage that data and to figure out what those indicators are for any particular person.
Sarah, Dr. Okoro, do you also have reflections when you think about moving the data measurement and analysis forward? What would be helpful for you all, or emerging areas of research that you're looking into currently?
Well, in North Carolina, we have developed a perinatal health strategic plan. Of course, preconception health is just one part of that, an important part, but just one part. And so we're trying to incorporate indicators that we really can look at more systems level than just the individual. And it's just so hard. So I'm looking at researchers and people like Isabelle and Kennedy and others to really lead us in that direction, because for so long we've done it more just let's fix this problem instead of having people well to begin with. As a former director of NCH in North Carolina, I always said the most important prenatal care visit is the one that most people don't get, and that's that preconception health visit. And it's not just, it can't just come down to a visit. It's got to be, the whole life course and all of that. Sarah said in a comment earlier about, Oklahoma, making sure that when we did the human-centered design to try to figure out what type of tool would work well in clinics to help people answer questions about their healthcare that day and how they were ready or not ready yet for pregnancy. It really does come to, we've got to include the community more and more and more. We can't just think that we've got it. I was intrigued, and I can't wait to learn more about the framework. I've got it pulled up here somewhere that was mentioned earlier in the week. The second, I don't want to get the wrong name. The creation of the cycle to respectful care is what it boils down to, and making sure that in our research we were also including the people that hearing the voices of everybody. I mean, that's what this whole last 2 days has been about. It's the stories, it's hearing the voices of the people that we aren't used to hearing from, and that is important in data as well as in qualitative things as well. I'm not saying that very well. Others join in on that, but it's just, it doesn't matter what data we are collecting if the biases and the type of care that we're giving don't help with that. It doesn't really matter what the data collects.
I'm just gonna piggyback on that. I think that's a really great point. One of our partners with Massachusetts, one of my colleagues, they recently in Massachusetts developed a racial equity roadmap in which they really not only started internally among their health department about how they view race and racism, but how does their data look at race in an appropriate way. And I think the more at all levels we do the same kind of activity and understanding how are we, either at the national level, the community level, how are we collecting the data and are we being mindful of the voices, I think again that we will eventually, we didn't get here overnight, so we're not going to solve it overnight. But I think the key is, are we moving in that direction? I think that's you were talking about a framework, and that's why that came to my mind. Is they also developed a framework which is specifically around racial equity, and it's around racial equity in data. So they looked at some of their specific maternal child health programs, and I'll make sure I put the link in the chat for those who are interested in checking it out, where whether it was their EDDI program or their McLeod program, where they looked at how are we collecting our data and how can we collect it more in a racial equitable manner. And I think the more we do that, eventually some of these, it's not gonna, most of the indicators are based on the two data systems, because again, those are the data systems we have. I think one of the other pieces of inclusion is how do we bring in stakeholder data? How do we bring in community-based data, and how can they also help inform this work? But again, it's really hard because it's not something that we all are used to. We kind of stay in our lane and we kind of do our work. But I think all of these things can help us as we try to think about what are the indicators. And maybe we could have different types of indicators. Like these are the federal level based indicators for these many preconception issues, and these are the ones that are based from the community, or you know what I'm saying? So just trying to figure out how do we get it all together is really, I think, an important piece of us moving forward.
And I think we are moving forward, because when we came up back in 2008, 2009, I was part of that initial states group to come up with the preconception health indicators. We weren't asking questions in the same way. We weren't talking about racism. We were talking about institutional racism. At least we're now talking about it. We're not there yet. We've got a long ways to go, but at least the questions are being brought up.
Thank you all. I really appreciate the way the discussion has moved, because I think that these are important elements. So what I'm hearing is being very clear that when we're capturing data on race, we're clear about what exactly we're doing. We're using race, understanding it's a construct, a social construct, and it's sort of a proxy for interpersonal and structural racism. That also we're cognizant of who is participating in developing these indicators. So having diverse groups of stakeholders present, and understanding what these really look like at the community level and how people are conceptualizing and interpreting these indicators, if they make sense, for folks who are actually seeking care. I want to point out a resource that we have linked to. There's a couple of resources that folks have shared. They've talked about the Cycle to Respectful Maternity Care that was developed by Carmen Green and other colleagues at the National Birth Equity Collaborative. I also want to mention the Do No Harm Guide that was published by the Urban Institute on applying equity awareness and data visualization. But I think their tips are more broader than data visualization. I think how we're talking and engaging in research in general. So one of the tips that was mentioned, Dr. Okoro reference related to our reference group. Why are we using white as our reference group? And being cognizant of being very clear about why we're using that as our reference group. Even in the surveys, they've listed or noted if we have white as the first racial category listed, why are we doing that? Is it because we see white as default? So this is important for each of us to constantly be thinking about ways that we can decolonize our own minds and decolonize our research practices, that we're thinking about the frameworks that we're using to guide our work and also our values. We don't have those conversations enough as to what are our personal values and how do they impact the research that we're engaged in and how we're conducting research. I see that we have 15 minutes left. I want to bring in Rio to share with us what you've been able to capture so far.
Sure. So you can see my screen. It's a little blurry likely. And I believe I'm going to be spotlit in just a moment. And I can highlight a few of the big themes that I was hearing. And so first, we started with this level setting and reminders that the preconception language is limiting. We need to be talking about systems and structures, center women, and also focus on gender affirming care. Then we got into talking a bit about what the indicators include, some of the challenges, how we're leveraging indicators, and then the meat of this conversation that I've heard is really around what's in the middle, structural racism and decolonizing data. And once we started talking about the supports that were needed, we also started flowing into how to hear the voices of those we're serving in the data collection, in the design of research, in the interpretation, in the sharing of data. And so I will let folks look at this for however long they want to, and pass it back to you, Isabelle.
Thank you, Rio. This is really wonderful. So again, we are going to turn it over to questions, accept questions from the audience soon. I don't see any in the Q&A feature. If there's others that were captured in the chat, I'm hoping that folks on the organizing team can help pull those out. But for panelists, we're going to close out soon before we jump to question. Oh, there's a bunch in the chat. Okay, thank you, Sarah. If you don't mind helping me pull those out, the questions. I do want panelists to offer some closing remarks before we jump to Q&A, either describing what we haven't covered that you wanted us to make sure that we covered today, or what you want the audience to leave with from this discussion. Sarah, would you like to start?
I guess I leave hopeful. It's been a tough week, y'all, for lots of reasons. Women's health care being one of the big things, but I do think I just appreciate the different organizations that are really working hard to make the data more representative, more useful. And it's pushing people out of their comfort zone, which we need to be. That's how we're going to get to move forward. We do need to increase sample sizes for some things. That's always just a limitation of some of the data, but we just got to be able to ask better questions of the right people and involve the people that we need to involve. And I'm not saying that very well, but I'm thankful for all the new information that is coming out, and just keep it coming.
Thank you, Sarah. Megan?
Yeah, I guess I would just kind of reemphasize some of the things I said earlier, in that the EHR is kind of a blessing and a curse, right? Like there's so much promise with this idea that we have all of this information available at our fingertips, but the practicality of using it in a clinical setting is sort of mixed, right? I know a lot of providers really don't enjoy having to enter data as they're working with a patient. They'd much rather be with that patient than be with the screen of a computer. So I guess creative ways on how we might integrate the EHR in perhaps a different way is something that we could look at in the future. One recommendation that I've heard is some sort of data mining in the notes field, perhaps, so that we can create queryable data from that note section, perhaps, because a lot of the good clinical information is captured there. So I guess I would just encourage us as a healthcare system to push ourselves forward and kind of using the EHR in a more practically useful way.
Thank you. Dr. Quinn?
Sure. First, I just want to echo what Sarah said, that I really am grateful for spaces like this kind of forum that really gives us an opportunity to step outside our just purely research bubble and think about not just the work that we've done, but how does it impact policy? How might it impact practice? Who are we actually serving? Who are we involving? That these spaces like this conference, this forum, are just, I think, really great. And I'm very grateful to have been a part of it, so thank you. But then also, this was a theme that was echoed repeatedly yesterday, and I'm going to say it again, that it's really important to me to not lose sight of the fact that what we're talking about when we talk about preconception health and preconception wellness, we're really talking about a person's whole health. And that a lot of the work that we've been able to do has been retrospective. So we start with a person who's already had a pregnancy and we work backwards to explore their health beforehand, but that the goal would be to be able to use all of these measures to improve health in real time, right? Not just to describe the health that has already occurred, good or bad. And that to do that in a clinical setting, I think it's really about getting a message. It's not just to patients. I think we put a lot of burden on patients. Are you doing the right things? Are you, and it's so much more than individual behaviors that impact health. And so getting a message out to providers and to broader systems, as well as to patients, that the care we provide or the care that we seek for ourselves or for others in our families today really has an impact on tomorrow. And so that really deepening this understanding that improving quality and equity in health and in healthcare is a life course question. It's not about this one particular period that we focus on. We're talking about preconception, pre-pregnancy, but that really healthcare across the life course is the underlying sort of ultimate goal, improving across healthcare across the board. And so that when we talk about preconception, let's not forget that what we're really talking about is the whole health of the pregnant person, long before they ever do or don't become pregnant.
Thank you, Dr. Quinn. And I think that's important too for us to keep in mind that we haven't mentioned this yet on this during this session, that preconception overlaps with postpartum for certain birthing individuals. We haven't had that discussion, and that's important to bring into this space. Dr. Okoro?
I just will say that I'm hopeful, just like Sarah said, that we're making progress. We've made progress thinking about the 15 years that we've been doing this work and how far we've come. And I know that as we continue to talk about it in these different spaces, that we will not have to wait another 15 years before we get to the next level. So I'm really excited about that. So thanks again for the chance to participate in this forum today.
Thank you all. And so now I pulled some questions from the chat that we can address. So has anyone seen any kind of community assessment that somehow elevates community risk assets and then puts population health indicators within that assessment? We know that to be what people need, supports around them. Apologies. Okay, we'll move on to the next question. So are there any movements in PRAMS or BRFIS that allow people who are non-binary or trans to indicate as such? Otherwise, we are stuck in these male-female dichotomies.
I will say that I'm not sure. I know PRAMS is currently going through its phase 9 revamping, but I'm not sure if there are going to be questions. And if there's anybody who is on the panel and or in the audience that are participating in this from their state, maybe that's something they need to bring up as PRAMS is kind of in this phase of revamping. Regarding RFSS, I'm not sure.
Thank you.
Isn't there some talk about birth certificate changes? I mean, I know they take forever to make, but in there, I mean, because PRAMS is based off of birth certificate data, so we would get a little bit maybe if they change the birth certificate, but that's a long process, we know.
And I think in the BRFSS, I never know if I should say BRFS or BRFS or spell out all the letters, but in that data set, there is an optional module that states can adopt that has additional questions, I think, about gender identity, but I don't believe that currently the core module offers that opportunity, but I think there's an optional module for states.
Thank you all. Another question. So I really appreciated Dr. Okuro's earlier point about using white people as a comparison group for racially marginalized groups. How can we build the conversation to interrogate why we use white people as the baseline and find more meaningful comparisons?
I mean, I will just say that I think that's what we've always done, and it's kind of tradition. And I guess the goal was thinking that it was the standard, and you're trying to make sure that people are meeting up to the standard. Again, as we're learning and growing, we realize that all the other populations are complex in many ways because many are made up of immigrants, refugees, and the definition of race and ethnicity is so much more complicated than we think. So I think that's it. But again, as we're trying to look forward, I think what's interesting and exciting is that we are starting to be mindful of this and trying to make sure that as we talk about a particular group or population, that are we making sure that as we're quote unquote having reference, are we doing it correctly? And do we need to have a reference? Maybe we just display the data as is and let people make their own interpretation versus us feeling the need to interpret everything at all times for people. So I think it's an ongoing thing. It's a hard thing for us as researchers because we want things in a neat box, but maybe that's part of moving forward.
Absolutely. I definitely have seen movement away from using white people as a comparison, not having a comparison across racial groups, but thinking about there's so much heterogeneity within racial groups, as you've mentioned, Dr. Okuro. So there's been papers that focus on Black maternal health that are only looking at samples of Black women and Black birthing people. And I think that's important for us to keep in mind. So you've mentioned earlier the variation, African Americans, Caribbean Americans, African immigrants, or African Afro-Indigenous peoples, there's limitations of the data, right? But with what we do have, we can recognize that there's opportunities to look within racial groups for the research that we're conducting. So those are all the questions that I was able to see in the chat. I really want to thank everyone for joining, particularly the panelists, but also the audience for participating in this panel discussion. I know that there are other sessions that will be happening later this afternoon and on the 15th. So with that said, I will turn it over to the conference organizers.
And I want to just say thank you, Isabelle, for facilitating this session for us. We really appreciate it. And thanks again to the panelists. Y'all are wonderful. I also do want to note there was a response to your question about the community health assessment that came in the chat, and that Oklahoma has an assessment tool that touches on the topic of whether or not the woman has a support system at home. It's not a community assessment, but it is a start in something that they can collect data on and track to see how many of their clients do or don't have support systems. So that was kind of an interesting alternative. But again, thank you to this wonderful panel. We truly appreciate you all for taking the time. You're wonderful. And stay tuned. We have our next session coming up at 1:30.
Hey everyone, so we'll take a quick break and come back for our next session, which will be reproductive life planning at 1:30. Be sure to check out our Future Forward Jamboard and share any ideas that you have there. Also, make sure to tag us on Instagram, Facebook, and Twitter. We're grateful to all of our speakers for sharing their insights with us. And you can learn more about our speakers and their work in the speaker section of the Conference Hub at beforeandbeyond.org/futureforward. We also want to take some time to thank the UNC School of Social Work for the technical support during these conference days. You can find all the details you need for the conference in that Conference Hub. The registration will stay open if others would like to join later on. And you can also find the Jamboard on the Hub as well. So you can share your inspirations, thoughts, ideas, and challenges for us to review throughout the day. So we'll come back at 1:30 for the next session.